Hello and welcome to the video presentation for Chapter 40 for Module 9 in Nursing 150. So Chapter 40 discusses care of the patient with acute coronary syndrome. Acute coronary syndrome is an umbrella term that sort of covers pain associated with unstable angina and a myocardial infarction. So this is a picture of the major coronary arteries. The left main is a pretty important vessel that comes off of the aorta here. And if you notice, the left main bifurcates into the left anterior descending into the circumflex artery. These arteries together supply blood to the left side of the heart. So if there's a blockage up here in the left main, if it blocks, there's 100% occlusion there in the left main, then as you can imagine, this large part of the left ventricle will be damaged. Everything below it will be deprived of oxygen, and it could damage permanently the left side of the heart, which would be very detrimental to the patient. Then you also have the right coronary artery that comes off, and it supplies blood to the inferior part and the right side of the heart. So basically what happens here in a myocardial infarction, or let's back up to unstable angina, in one of these arteries there'll be like a partial occlusion in the patient, so it'll deprive anything below it of oxygen. So when it's partially occluded, this area will start having some ischemia, which means lack of oxygen to it, and it starts to hurt a little bit. When this patient has got so much blockage that it's hurting even at rest, and it's not relieved by nitroglycerin or other medications, then it's called an unstable angina. And in contrast to that, a myocardial infarction will be when this area is 100% occluded, it's blocked completely, and this area down here has been deprived of oxygen for a longer amount of time and has actually infarcted the muscle. Myocardial infarction is something that doesn't happen suddenly. It takes a little bit of a time for this to kind of build up. There's a couple of pictures and diagrams on your book. Page 830 and 831 has some good figures. Figures 40-1 and 40-2 kind of explains how the myocardial infarction can damage the cardiac muscle itself, and then the areas of injury are shown there. So this slide just kind of helps differentiate the two. The ischemia, which would be occurring with the unstable angina, is insufficient oxygen supply to meet the requirements of the myocardium. The infarction is when the necrosis or cell death that occurs when it's severe and prolonged deprivation of oxygen to the area. It's just like if you think about an area, this is an artery supplied to, say, a foot. We'll make this a foot. It's not a very good foot. But if something, that artery that supplies that foot with oxygen gets blocked, it's blocked off. So initially the foot, with the deprivation of the blood supply, will start getting kind of gray, getting kind of cool, and it'll be painful to the patient. And at first it'll just be painful, it'll be uncomfortable, it'll start turning blue. The longer this goes on, the longer this area is deprived of oxygen and blood supply, the more damage is going to occur to that foot. It's the same thing with the heart muscle. So if you have your heart with the coronary arteries coming down, if this one's blocked, whatever's down below here, this area of muscle that's down below, at first it's going to start to hurt a little bit. And if that blood supply is continued to be deprived, it's going to start hurting more. And then this area is just going to be so compromised that it'll end up having irreversible damage to it. So that's why it's very important once we identify that somebody's having an unstable angina that we get them treated with the proper medication and potentially take them to a procedure to open up that artery. Just again, kind of identifying the different terms. Chronic stable angina is that patient that has that pain that occurs when there's an imbalance of the supply and demand of oxygen. So it typically happens when they are more active, when they'll notice it maybe when they climb a flight of steps, when they mow the yard, when they shovel snow, different things like that, and it will be relieved by rest. So your chronic stable angina, it will not result in any damage to the myocardium and not permanent damage to the myocardial muscle, and it's typically relieved with medications like nitroglycerin. Endur could be another medication because those are nitrates that dilate those coronary vessels and allow the blood flow to flow better to that area. It really requires aggressive treatment, but it does require monitoring. So if it gets worse, we want to monitor to make sure that it doesn't become an unstable angina. So this is just the proper definition of acute coronary syndrome. Like I said, it's sort of an umbrella term that covers the unstable angina or the acute myocardial infarction. And it's basically just referring to the fact that there's the coronary arteries, that there's a syndrome, there's something acutely happening within the coronary arteries. So angina becomes unstable when it is not relieved by rest. It's very difficult to manage. Nitroglycerin does not help relieve the pain. Typically, it's pressure that lasts longer than 15 minutes, poorly relieved by rest or nitroglycerin. There's different variations of unstable angina. New onset is just the first time a person has chest pain. It can be unstable, just unrelieved by rest. Variant or Prinzmetal's basically defines like a chest discomfort that is caused by the coronary artery spasming, and that can be from disease as well, but it's typically harder to control with rest because instead of it being a huge blockage there, it's more of a spasm in that coronary artery in relation to a disease process, and it typically occurs with rest. Pre-infarction angina is just referring to some unstable angina that's kind of giving us clues that this patient may be at high risk for a myocardial infarction. So chronic stable angina and unstable angina are always monitored very closely and taken very seriously because both of them can be indicators that a patient is at risk for a myocardial infarction, which we've already kind of said is a much more serious, abruptly severe deprivation of oxygen to the myocardial tissue. A myocardial infarction occurs when a large part of the blood flow is blocked to an area of the heart muscle, and it's typically abrupt. There's several different reasons. Most of the time it's atherosclerosis, which we talked about, is that buildup of plaque in the coronary arteries. Sometimes there can be an arterial spasm, like we were just talking about with the Prinzmetal's angina. It could be spasming. Anything that can occlude that artery and cause a lack of blood supply. Sometimes the patient will throw a clot, and a clot will just stop in the coronary artery and block the blood flow. The infarction that happens in the muscle can involve all of the layers of the heart muscle or may only involve the subendocardium. If it does spread to all three of the layers of the myocardium, it's called a transmural. And of course, as you can imagine, the injury is going to be worse if it's transmural. The transmural causes much more damage, and you're going to see a patient have more difficulty recovering, and you're going to see that patient's going to have a lot more effect on their wall motion, which can mean that they're going to have higher potential for heart failure of the heart muscle to pump adequate cardiac output after this kind of an MI. Basically, what happens after the heart muscle is damaged, the heart muscle initially is going to be somewhat stunned, and then the infarcted area over some time, over like 48 hours, and then building up over another week or so, it tries to kind of rebuild itself. 8 to 10 days after an infarction, it starts to form granulation tissue, and it form over the edges of the necrotic tissue. And basically, it kind of builds up a scar from the damage. And this scar tissue, it permanently changes the side of the entire left ventricle. So just thinking about what we talked about, how the blood should flow very nicely through the heart to get good cardiac output. If the ventricle, the left or whichever ventricle, has scarring and change in size, it's not going to be able to pump like it should, and they're going to have signs and symptoms of heart failure. So this is a picture that sort of shows the ST elevation that can occur with a STEMI, which is a ST elevation myocardial infarction. And that occurs typically when it's more of a transmural, more of an abrupt blockage that causes changes in the EKG. So this is a little bit hard to see, but this is what I want you to pay attention to here. Zone of ischemia. So we know that ischemia is when the blood supply is beginning to be diminished. So it's a lack of oxygen because of some blocked area where it's just beginning. So what we'll see on an EKG is some ST depression at first. As you can see here, the ST segment is pointed down. And then as the area of injury moves further, so now the patient's coronary artery has deprived a portion of the heart muscle from oxygen for a little bit longer, the zone of injury is going to get more, it's going to be injured now instead of just ischemic, and that's when you're really going to see that ST elevation. And that is a picture of an ST elevation that is absolutely going to make people run fast to the cath lab, because right now that's when injury is occurring. Up here with this depression, it's ischemic. It's that foot that's starting to turn a little bit pale and get a little bit cool. And then once they see this, they know that injury is occurring. So now it's been deprived of oxygen for so long that now there's an injury occurring. Once it gets to, there's a couple things that happen when we get to the zone of infarction, which means we have permanent damage. What's going to occur on your EKG is you have if you can see this Q wave, this Q wave is way more pronounced than it is up here. So you have a more pronounced Q wave, and then your ST elevation. You're going to start seeing that depressed T wave at the end of the ST elevation. So this is what they're looking for in the 12-lead EKG. If somebody comes in with chest pain that's unstable and they're starting to see ST depression, they're going to be moved to the cath lab, but we're not going to run quite as fast. We're going to get them there pretty soon because we see that they're getting to be in trouble. If we see that this injury is occurring, we're going to run like mad. We got to open that vessel soon. And then after we get down to this further part down here, when it appears that there is an infarction and happening right then, they are infarcting, we will run pretty quickly too, because we know that the longer that vessel is left blocked, the more difficult it is going to be for that patient to recover from that infarction. So hopefully that's a good picture to kind of help you understand the 12-lead EKG and what we're looking for, and why we do it right away when somebody comes in with an unstable angina. And if they come in with stable, we'll definitely do a 12-lead EKG just to see what's going on in there. All right. Talking extensively about the modifiable factors, non-modifiable for coronary artery disease. Age, of course, as we get older. Lots of different things happen in our body that make us higher risk. Your cholesterol just may go higher for a lot of different reasons. Women, when they reach menopause, when they've gone through menopause and above, they have less estrogen available, and that makes them more at risk for cardiovascular disease. Gender, men are still more at risk for MIs, but women are catching up, and they just typically get sicker from it. Family history, absolutely. And here's the big thing about the family history. If you have a first-degree relative, which would be a brother, sister, mother, father, with coronary artery disease at a young age, I think they kind of use the rule of thumb of earlier than 50, then that makes you at extremely high risk for developing coronary artery disease. And you need to make sure that they're doing preventive factors, like they're checking their cholesterol, they're taking maybe a baby aspirin, maybe they'll go ahead and even put them on a statin, which is that cholesterol-lowering medication, as a prevention. They'll put them on like low-dose aspirin, low-dose statin to try to prevent them from getting it. So there is definitely a familial history. There's also a known fact that people with high cholesterol, typically, that runs in families as well. It doesn't matter what their diet is. If they have a family history of just those kind of people that produce more LDL cholesterol, they're going to have it. And they're just basically, the bottom line there is they just need to know it and treat it and prevent it. Ethnic background, of course, there is some ethnicities that it is a higher risk in. There's a good cultural awareness box in your book on page 832. Talks about African American and Hispanic women have a higher risk for CAD, coronary artery disease. Lots of different risk factors there. The leading cause of death for both men and women in the Euro-American population is cardiac disease. So these are non-modifiable risk factors. Things we can't change. Can't change where we come from. It can't change when we get older. But we can certainly just be educated about our risk factors and just try it. There's lots of things now that we can do. We need to do those screenings, get that cholesterol checked, get this blood pressure checked, put them on some medicine to treat that early, because we know that if we don't, then they could end up with a myocardial infarction. So modifiable things, elevated serum cholesterol, sure. Some people can't control it with diet because it's in their genes, but they can certainly get on something called a statin medication, like your simvastatin, the atorvastatin. Those are all meds that can lower your cholesterol. Cigarette smoking, absolutely, all these things. Hypertension, impaired glucose tolerance, especially if it's poorly controlled diabetes, obesity, excessive alcohol, sedentary lifestyle, which is the limited physical activity, can definitely put you at risk. They're saying now people who have high BMIs, and then not just the high BMI, but if they are larger around the middle, the bigger they are around the middle, and I'm talking like their belly, the bigger you are there, the more at risk you are. So the more weight that they're carrying around their midsection, the more at risk they are. Stress cannot be understated. Stress, those type A personality people are so much at risk. They can be active people, but that stress after a while, it's people who have that type A personality. They're go, high stress, jobs, just constantly under a state of stress. They're never getting any rest. They are just constantly putting a toll on their body, and it really does put them at risk. And a lot of times they don't eat right. They're doing things to control their stress, like drinking and smoking. So, like I said, it can't be understated. That's one of the number one things that I've seen is very stressful people who just need to slow down. Because a lot of times when you talk to people who have chest pain, they'll tell you that stress brought it on. It was brought on by stress. Like some big event happened in their life that was just a lot for them, and then they'll get chest pain from it. So like I said, it's one of the big causes that I've seen of chest pain. So these are lab assessments that we'll do to determine the what is causing a patient to have chest pain. Troponin T and troponin 1, they are cardiac enzymes. They are enzymes that are produced by any damage to the myocardial tissue. So normal troponins are negative. So if a patient has any elevation in their troponins, that is an indicator that there has been damage to the myocardial muscle. CKMB is also it's creatinine kinase. It is also an enzyme that occurs with cardiac muscle damage. The thing about CKMB is it won't elevate right away. So they might do that just to kind of monitor timing, but the problem with it is it just does not occur quick enough for us to be able to determine what's going on with the patient, so we stick with the troponins. They're specific to the cardiac muscle and they're quick. The elevation occurs quickly, and we need to know that right away. Imaging assessment is, they might have to do a chest x-ray or maybe a CT scan if they're trying to rule out something else. Sometimes there's a few different things that can cause chest pain and shortness of breath, which they could complain of with unstable angina, and a PE is one of them. It can cause some chest pain, which is a pulmonary embolism. Any pneumonia could cause some difficulty with breathing and some chest pain from coughing. So a lot of times they'll do a chest x-ray just to rule that out. They can also see the silhouette of the heart with a chest x-ray, so that might help them just gain a little bit more knowledge. 12-lead EKG we've talked about, or the ECG, which gives us 12 views of the heart, so it can help us to determine if there's something acute going on within the heart. Cardiac cath, that's that invasive test. So that's when they have to go to the cath lab and they insert an introducer and then a guide wire that'll go up through the heart to take a look at the coronary arteries, take a close look to see if they're patent, see if there's any blockages. And that is the only invasive one. The cardiac cath is the most invasive. So they start out, with the 12-lead EKG. They're going to do the troponin, maybe a chest x-ray just to rule out anything else. They might just do the CKMB just to kind of help assess timing. Myoglobin is just another test that would is in some enzymes that are elevated with myocardial damage. We don't do it a whole lot anymore. We basically really stick with this troponin. It's usually the most informative for us. So for pain management, somebody comes in with an unstable angina, we are going to sit them in a position of comfort, and that is typically semi-Fowlers, but wherever they're comfortable for the most part, whatever feels good to them, it feels like they can breathe better, because we want them to be comfortable. We don't want them to be stressed. That's why we want them in a quiet, calm environment. Nitroglycerin, remember, is sublingual typically. We'll give them one under their tongue, let it dissolve. It is a nitrate, so it should dilate those vessels and relieve the pain and let some blood flow through. We'll give up to 3 doses every 5 minutes, and we got to monitor that BP, monitor blood pressure, because it can drop their blood pressure a little bit. So you just keep an eye on it, make sure you're not dropping it too far. And then the other thing is they're going to get a headache, and that's okay. I'd rather have a headache than a myocardial infarction myself. So they will tell you they have a headache, but just, kind of tell them, we'll treat it. It's going to be okay. We still have to do this. If they continue to have pain, some morphine. Typically we give like 2 milligrams IV. It works quick, works well usually, relieves pain. Again, you just want to kind of monitor their blood pressure when you're giving all these meds to make sure that it doesn't drop too far. And of course, apply that oxygen. Because like I said, right now their heart muscle needs some extra oxygen. So really, I think we talked about this during the simulation. All of this kind of is occurring at the same time. You know, there's lots of people working, so you get calm, quiet environment. You try to get them comfy, put some oxygen on them, give them some nitro. If they're still continuing to have some pain, then you can give them some morphine as well. We got to get them pain-free. That's our goal. We want them to be pain-free because the more pain they're in, the more they're stressed and the more oxygen demand they have. So we want to just chill them out, basically, until we can decide further treatment. So again, our goal is to get reperfusion back to that coronary area. Aspirin and thrombolytic agents are options. They will go ahead and typically give them an aspirin to chew up. Thrombolytic agents, we could actually inject. That's your streptokinase. Those are listed on your module outline. We don't see this a whole lot anymore. Basically what they are is like clot busters. You can inject them and hope that they dissolve the clot that is formed in the coronary arteries. But we have so many different interventions now that are a little bit safer that you don't see a whole lot of those thrombolytic agents utilized anymore. Restoration of perfusion to injured area limits the amount of extension, improves left ventricular function. So all of these meds together, and if needed, we might have to go to the cath lab to do that, to get that restoration of perfusion to that injured area. And of course, the sooner we do that, the better off your patient outcomes are going to be. So this is a list of those. TPA is one of them. That's what we call this. We call this TPA. These are clot busters that you can actually infuse into the patient in an IV, and it could restore myocardial blood flow that way. Again, I haven't seen this used in a very long time. Typically, I think anymore, it's only used if you can't get the patient to a cath lab fast. So it might be something that's utilized in an area that doesn't have a cath lab very close and available. So it's basically just medication that they would inject into a patient's IV that could dissolve the clot in the coronary artery and restore blood flow. We have such good results with the cath lab, and we can be so quick about it these days that that's typically what we do. So these are other medications that are used to treat unstable angina, or it could be given after a patient is treated for myocardial infarction. All of these are also blood pressure medications. Beta blockers block the beta receptors within the heart. Those beta receptors respond to stimulants such as epinephrine. So those beta cells in the heart, when they are exposed to epinephrine, it causes the heart rate to go up. And we don't want that to happen with somebody who is having a problem with supply and demand, because when the heart rate goes up, then the demand goes up. So these beta blockers block that. So if epi wants in, which is a big vasoconstrictor, it's that fight or flight response. It gets the body ready to fight, so it gets the heart rate up, it constricts the vessels. But beta blockers, they block that. So now epi cannot get to the beta receptors in the heart. So it keeps the heart much more chill, keeps the blood pressure from going up, keeps the heart rate from going up. So it helps the heart rest, essentially. ACE inhibitors kind of work the same way, but they work in a different area. So they work on that renin, aldosterone, angiotensin receptor areas in the kidneys. And they respond to, if you remember, this all responds to hormones coming from the pituitary gland. And what they do is they try to elevate the BP. But if we inhibit that or we block it, we keep the blood pressure nice and chill. So it's just another area that we work. Calcium channel blockers work in that. It works in the area of the heart, but it's more of the where the calcium affects the squeeze of the heart. So it kind of blocks the effects that calcium has on the heart. And that, again, will keep the heart less responsive to stress, and it'll keep it nice and chill and keep the blood pressure down and keep the heart rate down so the patient's heart is not so irritated, and because we don't want it to work very hard right now because it doesn't have the blood supply to work as hard. It needs to rest. So it's basically all these meds are given to rest the heart muscle. The thing you have to monitor the patient for is that it doesn't make their blood pressure too low. All of these can also lower your heart rate, so you got to monitor your patient and teach them to monitor their heart rate so that it doesn't get too low, and make sure that the dose is managed well. So basically just definitions of what can happen if the myocardial tissue becomes ischemic and necrotic. The thrombolytic therapy can just open up those coronary arteries and restore myocardial blood flow. But again, like I said, we don't use these a whole lot anymore. We typically go with the intervention in the cath lab to open up those vessels. So this percutaneous transluminal coronary angioplasty is just referring to that intervention. It's when angioplasty typically refers to going in with a balloon and opening up that artery by inflating the balloon in the area where the plaque is. And they typically like to anticoagulate them while they're doing this. They want to keep their blood thin so that when they open up the vessel, the blood can flow through there without clotting or anything like that. So clopidogrel is also known as Plavix. It is something, if they put a stent in a patient, in a patient's coronary artery, they have to be on clopidogrel for, depends on the patient, but typically it's a good 6 months or more that they put them on this medication. And that is a platelet aggregator. It sort of works like aspirin. It keeps the platelets from sticking together, so it'll keep the platelets from sticking to that area that we went in and kind of irritated a little bit. So that's why they have to take it, and it basically keeps that stent from occluding. It keeps that coronary artery from re-occluding. They might have some heparin after the procedure. That's again just to keep their blood thin so that everything remains open and no further clots are formed. Heparin is a good preventer of clots. IV nitro or diltiazem. Remember, nitro is a nitrate. It's just a good dilator of those coronary vessels, again, to let that blood flow. Diltiazem, again, kind of decreases that push and squeeze of the heart, and it just lets it rest. After someone gets a stent or an angioplasty, long-term therapy, they will keep their blood thin. It's usually that you have to take an aspirin or a Plavix, which is this drug right here, to keep that coronary artery open. Beta blocker to keep the heart nice and chill. We don't want it working. It has had an event that could have injured a part of it, so we don't want it going crazy. We want it to stay chill. They usually will put them on a beta and an ACE. And remember, the betas and the ACEs work in a little bit different areas in the body, so together they work really well to keep the blood pressure down and keep the heart from working too hard. Or an ARB, so they can do an ACE or an ARB. An ARB is basically, it works in the kidneys as well. A lot of times people cannot take an ACE inhibitor. There's lots of different side effects of an ACE inhibitor. The biggest one is being a very, very obnoxious cough that it can give them. It's a dry cough that can keep them up at night. So they usually start with an ACE, but if somebody is unable to take an ACE, then they'll switch them over to the ARB. That's basically why ARBs were developed, because it doesn't cause that cough. So if somebody can't take an ACE, then they'll put them on an ARB. The other thing about an ACE inhibitor is a very rare but life-threatening side effect is something called angioedema. And we talked about that when we talked about anaphylaxis. It can cause swelling of the face, and that angioedema, the face, the tongue, the mouth. So it could be potentially a dangerous, life-threatening situation. But like I said, it's a rare side effect of ACE inhibitor. I've seen it one time in my clinical practice. All right, so this is a great picture of that percutaneous transluminal coronary angioplasty. Remember I said angioplasty is the deployment of a balloon. So they'll take the wire, usually up through the femoral artery, up here, and you can kind of see in this picture, this is the wire here. You can see the wire going through there. And then that's where they're deploying the balloon right there. So the wire comes up through the femoral artery up over into the aortic arch there and down through the coronary artery. That's how they get to it. There's the plaque sitting there. They open it up and hopefully it stays nice and pretty and open like it is right there. But they got to take their anticoagulants. They got to take their betas to keep their heart nice and chill. And a lot of times they put them on a statin too. I don't care what their cholesterol is. They'll go ahead and put them on a statin. There's simvastatin, atorvastatin, pravastatin's another one of them. But they're those cholesterol-lowering medications. They have also found that those statins have a anti-inflammatory type effect. And we all know that this blockage that occurs here is kind of an inflammatory response. So they think it also protects the heart in that way as well, besides just lowering cholesterol levels. Here's a picture of a stent. I have some better pictures, and you can look this up yourself in the American Heart Association of how these stents are deployed. Pretty cool stuff. So they put them on the end of this guide wire. They are tiny, tiny, tiny. They look sort of even smaller than like a spring that you would see in a pen. So basically they load it onto the catheter wire here, and then when they get it up in that area, the doc has like a little thing in its hand that can actually deploy this stent and open up the coronary artery. Again, they have to take Plavix with these stents, which is, that's not the generic name, but, and it's, again, it keeps that stent open. So our goal would be to do the coronary, the cath lab, the percutaneous coronary intervention, because it's less invasive. We're just going to open up a femoral artery. They typically recover well from it. They have to lay flat for a while. Usually they have to monitor the site in the femoral artery for bleeding. They have to do lots of precautions, hold pressure on it, and not, their activity is decreased for a couple of days. They're not supposed to lift anything, usually that weighs more than a gallon of milk. They're not supposed to do a lot of steps. So it's less invasive, but there is a little bit of precautions afterwards, but it's really not a huge life-changing event. There are those patients that cannot have that blockage open by just a cardiac catheterization. The angioplasty or the stent placement may not be what they need, because there's just some blockages that cannot be fixed with a cardiac cath procedure. So these patients might have to go for a coronary artery bypass graft. What this means is we actually have to open the patient's chest. This is open heart surgery, basically, is what this is. So we have to open the patient's chest, and then we have to put them on bypass. So we have these bypass machines that they cannulate the heart. So they have these different areas where they kind of cannulate the heart, and these pumps outside of the body kind of do the work of the heart for a little while. So it's pretty big production. This is a much more serious and invasive event than your cardiac cath. So they open up the chest. They have to do a midsternal incision. They have to cut open the sternum with a saw, get to the heart, and then they will take a vessel from somewhere else in the body. They typically take a vessel from your lower leg, which is called a saphenous vein, or they'll take a vessel from inside the chest, which is your internal mammary. And what they will do, if a patient has a blockage right here in this coronary artery, they'll take that vessel that they took from the leg or the chest wall, and they'll sew it up here. And then they'll take it down here, and they'll sew it down here. So basically what they create is a bypass. That's why it's called bypass surgery. Now we cannot get blood through here, so we're going to create an extra little way to get around it. So the challenge here is to make sure that these vessels stay patent, that these vessels do not spasm. So can you imagine what those cardiac thoracic surgeons do? They have to have hands that can sew a vessel like that without harming it, without damaging it. It's amazing to watch. And it's amazing that we can do it. So, if they can get this to flow, if they can get blood to flow through there and get it to do its thing, then this will just be gone, and we'll have created a new pathway for the blood to flow to those areas of the heart. Some people, you hear people getting multiple bypasses. They can do this in multiple areas, and people do. They recover well from it. It's a little bit longer recovery, of course, but it can be done. These are just some different pictures of how grafts can be done. Remember I said the saphenous graft, that can come from the leg. That's a saphenous vein, or you have your internal mammary gland, and that can come from inside the chest wall. So, and this is just a picture of it sewn up here and sewn down here, so we can bypass an area there. Postoperative care is a little bit more extensive. A coronary artery bypass graft. Pre-op, and a lot of it, pre-op care is teaching. The ultimate goal of these patients post-op is they have to cough and deep breathe to get them out of there, because they have a chest incision that hurts like crazy when they cough. So you have to get them their management of their pain and get them to cough and deep breathe. And then we got to get them moving. The quicker that occurs, the better off they're going to be. And then you want to manage a lot of their vital signs. We want to keep them on. They're going to be on those betas. They're going to be on those ACEs, because we want their heart to just be chill. We don't want it working too hard. We don't want to try out those grafts just right away. We want them to, just let them heal and let that area where we sewed them in just work its magic. They usually need some rehab. They need some cardiopulmonary rehab to get them back up to their stability that they had prior to. We want them to get back working, and just monitor them. There's change in the level of consciousness is listed here. You got to monitor that with these procedures, because they are at risk for throwing some clots. And remember, changing a person's level of consciousness is always something that you should always be ready to treat. Figure out what is causing it, because it could be hypoxia, it could be a stroke, it could be so many different things that can be very, very serious. So always be on the lookout for a change in level of conscience on a patient. This concludes chapter 40 for module 9. So just make sure there's lots of questions, and especially some good case studies here that you should review in order to assess your understanding.